Journal of Comprehensive Dental Care. He has been invited to present at several national and international radio talks and Rotary clubs. He has an extensive organizational experience and is the honorary secretary in the Indian Society of Periodontology and has been a part of Indian Dental Association as the honorary secretary of Udaipur branch and joint secretary of Rajasthan state branch. So today we have Dr. Balaji, who will be speaking on Furcation, a clinical challenge. Sir, the stage is yours. Welcome, sir.
Thank you, Dr. Chetan. Thank you for kind words about me. I will share my screen. Is my screen visible?
Yep, it is.
Okay, great. Just I think the admin can do the admission part. Yeah, thank you.
We are doing, Doctor. We are doing.
Right, sir, right. Thank you very much. Warm winter morning. I hope it must be really cold in Lucknow. Here in Bhubaneswar, it's not cold at all. Thank you very much to Saraswati Dental College, headed by Dr. Dubey sir, and the Perio department headed by Vivek Bain sir, and of course my dear friend Dr. Chetan, who introduced me. I thank you all for having invited me to give a small talk of whatever I know or whatever I have experienced in my 22 years of specialty periodontal practice to share with you. Thank you very much, and I should really congratulate the Department of Periodontics for having started this Perioshastra. Well, the spelling says Shastra, but it can be read as Shastra also. So I think we have to really make this Shastra as the Shastra for us to fight the periodontal disease. And incidentally, the last 3 sessions which were there, which I attended, I'm glad, Vivek sir, I am the first male speaker to be invited to this podium. Thank you very much. Just on the lighter part, sir, lighter part. So just to set the tone up, that's all. Thank you very much once again. This is Kalinga Institute of Dental Sciences, where I am working, and my college is part of the Kalinga Institute of Industrial Technology, deemed to be university, which is an institute of eminence, the tag being given by the Ministry of Human Resource Development, Government of India. And it's a proud feeling to state that it is one of the only 8 universities in the country which have got private universities, I should say, which have this tag which has been given from the university. It's all because of the hard work of our founder, honorable founder Achyut Samanta sir, who is also a member of parliament from Odisha. So a few years back, I came across a tweet on the Twitter which said 4.8 billion people own mobile phones, whereas only 4.2 billion own a toothbrush. Well, this is a worldwide data which has been put here. So you can imagine the amount of knowledge or amount the people care about oral hygiene. They have mobile phones, but owning a toothbrush is not being considered as an important aspect for having a healthy oral cavity, which would lead definitely to the healthy body as well. So we all know that periodontitis is a chronic disease, second most common disease, dental disease after the dental caries to affect the mankind. And it is really a challenge for the dentist or the periodontist to treat or fight this periodontal disease. We all know it's multifactorial, a lot of things are going on. I'm not going into detail of all those things, but it is definitely a challenge. And if you can think, or if you can see, if you go around the rural part of India, in the villages and all those things, probably where electricity is not much, you will see fields which are being irrigated by the Persian wheel. The oxen go around the well, round and round they go around the well, and you can see this Persian wheel where the water is drawn from the well, and this water goes to the field to irrigate all the uh, uh, crops which are kept, which are planted or which are stored over there. Now imagine these oxen do not go around this well for, let's say, 4 days or 5 days. What is going to happen? Well, definitely, we all know the water is not going to come out of the well, and the field is not going to be irrigated, and eventually the crops will go dry, the field will grow dry. So if you can draw a parallel, and you can imagine if an individual does not brush for 4 days, 5 days, what is going to happen? Definitely, gingival inflammation is going to set in, and after the inflammation is there, we all know it is going to slowly lead to the periodontal disease as well. So this is just a comparative picture I had taken when I was in Rajasthan. I found it very interesting to click this picture, and I didn't know that I could draw a parallel out of this. Anyways, so if we see, one of the most important aspect when we are seeing in periodontal disease is the involvement of molar teeth. And we all know that invasion of the bifurcation and trifurcation of the multi-rooted teeth by periodontal disease is termed as furcation involvement. We all have read it in our textbook, clinical periodontology, Carranza or Glickman in older days. But if you see the AAP definition in 1992, it refers to as pathologic resorption of bone within a furcation. So we all understand that furcation involvement is a very important aspect, and it has got a lot of meaning, because when a patient comes with this type of furcation involvement to a general dentist, he either does not have that much of clinical acumen to treat this case, so he might just not do any treatment or just extract the tooth, or maybe if he is a little knowledgeable but he understands that it is beyond his capacity to treat such a case, he might refer the patient to a periodontist. But eventually, if you see, if a person who is practicing implants, he would think, okay, another 5 years, this tooth is going to get more bone loss is going to occur. So I might as well extract it and place an implant. But being a periodontist, it is very important for us that these teeth which are getting involved, we are there, or we should be able to save these teeth. And why we have to save these teeth? Is there something special about special about this teeth or special about this tooth? Yes, definitely. The most important role in the dentition molar teeth is considered to have is the contribution to mastication. Because they carry a considerable amount of the masticatory load. So we know that the molar tooth is really very important. And if you read the articles or studies way back in 1967 and 75 by Bates et al. And all these people, I have not written all these things over here, but you see that the molar is considered to be the tooth which is taking up the main important role of the mastication, and then it is also considered to have a big role in preparation of nutrition to the body. So it's a very important tooth in the oral cavity, and it becomes very imperative that we save this tooth when we are having a molar which is involved with periodontal disease. Of course, the molar tooth, because of its complex anatomy, the tooth having different types of problems on it, the furcation region being very small, the instruments do not enter the area, and all these problems are there. But it becomes very important, we, all of you who are budding periodontists over here, that we understand the anatomy of the molar tooth, and we really take a lot of trouble or to save this tooth so that it can be maintained in the oral cavity. If you read the article by Bauer, I don't remember which year it was, he has mentioned the morphology of the furcation. There are basically 4 types of morphology which he has mentioned. You can see the pictures A, B, C, D. The first picture shows where the roots are really separate from each other. It is having a very open furcation. The picture B shows the tooth in close contact, rather very closely present to each other with a very small space between the two roots. Molar has got two roots, and you can see that the furcation distance of furcation from the CJ is about 7 millimeters away. Similarly, in the first molar, you have the buccal root, the mesial root, and distal root. So these are the distances which have been. Can I ask? Please mute the mic. Yeah. Thank you. So these are the basic distances or average distances each root or the furcation is having on each root from the cemento enamel junction. Similarly, on the mandibular molar also, we know furcation is there only on the first molar and second molar we have taken over here. The buccal furcation and the lingual furcation, which we see, you can see it's about 3 millimeters on the buccal side and 4 to 5 millimeters on the lingual side in the molars. So what is the etiology of this furcation involvement? We all have read just to brush up for you all to understand that first and foremost, the primary factor is the plaque associated inflammation, which is giving rise to the inflammation or which is giving rise to the furcation involvement. And perio lesions, definitely these are also has got an important role to play. Trauma from occlusion, the load which is being distributed, if it is going to be the only tooth which is bearing all the load in the tooth on the arch or on the particular side, definitely there is going to be some involvement of the furcation. Fractures on the root, iatrogenic dentistry, overzealous root planing sometimes, yes, leads to the furcation involvement also. And some predisposing factors, like I already mentioned, the enamel projections which might be present, which acts as a nidus of plaque accumulation, and its proximity to the furcation region will definitely lead. And the alveolar housing, if the thin alveolar housing is present, the amount of inflammation which would have been required when the alveolar housing is thicker to cause the furcation involvement definitely reduces, and it causes more amount of gingival inflammation and destruction over there. So what are the problems of the molar tooth when we are seeing the furcation involvement? We have already seen in the article before also that the initiation of the gingival inflammation occurs more or less in the molar region, and the progression and persistence of the local factors, the gingival inflammation, and also the presence of calculus in the area leads to the initiation and progression of the disease. And difficulty in debridement, definitely because of the complex anatomy of the area, instrumentation becomes very difficult, and prevention of the accumulation of plaque and debris is going to cause problems for the molar teeth over there. There's a very nice article which appeared in Journal of International Academy of Periodontology 2015. I would request all the PG students definitely to go through this article. It's a wonderful article. It says about the realities and limitations of furcation measurements. It's a beautiful article. I am not going to tell you all the classification, but I have just put up here. I myself was very surprised to see there are about 20 classification for furcation involvement or furcation measurements. So PGs, make note of this article. You should definitely read this article. And you can see I have listed out the classification over here, right from 1953, the Glickman's classification, which we use very commonly, or our favorite classification, which we are doing. And it goes on, and you can see the various classification over here. Just I'm keeping it for 3 seconds for you to see. 11 number, you can see Tarnow and Fletcher, which we use for the vertical component. And the 18th one, Houchin Sai et al.'s classification, which has both the vertical as well as the horizontal component incorporated in a single classification. But number 1 and number 11 remains our favorite. Whenever we are asked to classify, we definitely give classification: horizontal component, the Glickman's classification, and the vertical component, Tarnow and Fletcher's classification, 1984. So please go through this article. It is very nicely written. Now to come to the diagnosing the furcation, we all know clinical assessment is the most easy or most important way of assessing the furcation involvement. We have the neighbors probe, which we are going to insert into the furcation region. For the maxillary, we are trying to put it from the mesial or the distal aspect of the tooth to see the furcation. And for the mandibular, we are putting from the buccal and lingual. Another technique is your transgingival probing, where we are trying to put after anesthetizing the area, we try to put the probe through the gingiva to see the bone sounding, which we call, to see the anatomy or the extent of the alveolar bone, which is present in the furcation region. Now, in the same article, you would come to know, we all commonly say neighbors probe, but to use for the, to see for the, just a minute, sir, yeah, to see the furcation. But you would be surprised to know the types of neighbors probe which are available. So many of them. We have different types ranging from the regular one which we use, which is the neighbors probe 1N. Then we have 2N. We have Q2N, so on and so forth. So please go through this article. You would definitely love reading the article to see the different types of probes, which are neighbors probe, which are available to assess the furcation involvement. The other methods of assessing the furcation also has been described, which we do not actually use, but it is really wonderful to know that furcation can be measured using the periodontal probe horizontally, as well as then when the probe goes into the furcation region, you keep another probe horizontally over it so that you can measure the depth to which it goes. Using endodontic stoppers on the probe to put it inside to see how much of horizontal bone loss has occurred in the furcation region. Putting molar tube, or rather more bracket, orthodontic bracket over here. So this, when the orthodontic bracket has been put on the stent, it actually gives the same level at which you will measure the furcation pre-operatively as well as post-operatively. These two techniques, when you are doing, you may not be inserting the probe at the same area as pre-operatively and post-operatively, but when you are putting this bracket over here on a stent, you would be probing the area at the same level as you did pre-operatively. Similarly with molar tube also, molar tube has been attached onto the stent, and you can see the probe is being put into the furcation area to measure the vertical distance or vertical loss of bone which has occurred in that area. Now the periodontal probe has been used, so you can see the gradations on the probe also, so that you will know how much of vertical loss has occurred in the area. Other techniques, the surgical measurements have been mentioned, where open bone measurements with probes has been mentioned. Basically, it is done when you are doing the surgical procedure. You will have to reflect the flap, buccal flap, as well as the palatal or lingual flap, and measure the furcation with your probe in that. And well, the basic point here is that you will have to open the area or surgically elevate the flap to check the bone or to check the furcation region. Another technique, interesting technique, which has been mentioned is the impression method. Again, here you have to reflect the flap, and you can use the impression material, which is probably the silicon-based impression material, which is injected into the furcation region on lingual side as well as the buccal side, which will give you the exact, or rather the material will flow into the furcation region, and then you can make the measurements on the impression material as to how much of the bone, or rather the furcation involvement, is present. Only disadvantage being here that it is surgical technique. Will have to open up the flap to do the measurements. There are few mathematical, or rather one mathematical algorithm also which has been mentioned. This appeared in the article in 2003, and Bowers has mentioned this type of calculation of the furcation defect. Uh, Again, here reflection of the lingual and facial flap is required for linear measurement of the defect. It's really a little bit complicated because you have to take the probe and you will have to measure, and then he's given the formula. If you can see, ROF minus BOD whole square into RDCB into HBODF and all these things. You can note down the article. If you are really interested, you can read the article and find out. But I feel it's a bit cumbersome method. You know, you have to measure everything and divide, multiply, divide, and all those things are there. And obviously, you need to know the furcation anatomy really very well, because you need to see the roof divergence where at the crest. You need to see the roof of the furcation, and all those things which have to be very crystal clear. A little bit cumbersome, time taking, but definitely as a postgraduate student, if you are thinking, or if your question is being asked maybe in theory paper or in viva, methods of methods of measurement, you should not miss this at all for answering, which might definitely fetch you more points or more marks when you are answering the mathematical algorithm when measurements are being done. The adjunct or adjuvant in your clinical diagnosis or clinical assessment of the furcation definitely is your radiographic assessment. And when we are doing the radiographic assessment, we all know we have the facility of the OPG, which is shown in figure A, which will show you the amount of bone or residual bone which is remaining. We have the facility of IOPS, which is shown in D, which will show you the exact amount of bone present in the furcation as well as the neighboring areas. And as time has advanced, we all know now we have the facility of cone beam computerized tomography, which actually gives us the correct picture as to how much of residual bone is remaining and what type of bone is there, what defect is present, how much horizontal defect is there, how much vertical defect is there. We are able to see slice by slice, which has solved so many of our problems in imaging. When we are talking about the imaging, when I told you about the CBCT, which is being used for the radiographic assessment, an article published in JCP in 2010, which shows the accuracy of the 3D imaging in assessing maxillary molar furcation involvement. You'd be, I'll not say surprised, because we all know that it is giving us about almost like 100% accuracy it gives. But this article, where it was, when it was published, it was done on 14 patients and 75 furcations were estimated in this type of, in this study. And of course, those patients also underwent the periodontal therapy, or rather flap surgery, or whatever therapy was to be done for them. 84% of the CBCT data was confirmed at surgery. So whatever the CBCT showed, the operators during the surgical procedure found out that yes, this coincides. There is almost similarity. 84% similarity was there. 15% of them showed that CBCT underestimated the bone loss, and only 1% of the case showed that there was an overestimation of the loss, bone loss, or rather the furcation involvement bone loss in that area. So CBCT is definitely has come a long way in helping us periodontists in assessing radiographically the amount of bone, residual bone for us to play with, maybe in doing periodontal therapy or maybe in the implant therapy as well. So whenever we are having access to these advanced imaging facilities, we should definitely make use of these things so that we are able to justify what we are going to do for the patient. When we are doing these radiographic and clinical assessment, there is definitely influence of the investigator's experience which comes into play over here. There is an article which has been published in the, again, Journal of Clinical Periodontology, which was way back in 1988 regarding the inter-examiner reproducibility of pocket depth in molar furcation sites by Moriarty. And he says, well, they used the true pressure sensitive probes over here and reported that the horizontal probing depth measurements were not consistently recordable, and that the reproducibility of the facial and lingual sites decreased with an increase in probing depth and an increased degree of root separation. So at the same time, Grides published an article in 2014 in Journal of Periodontology, where he mentions about operator experience in interpretation of the radiographs enhances the predictability of the radiographic measurement and therefore the right diagnosis. So these are two contradictory things which have been shown over here. So to avoid the investigator bias, the intra and inter-examiner calibration is a must for probing and for the radiographic assessment. So these are just for the postgraduates to understand that there is a need for, or rather there can be influence of investigator, his experience on reproducing the data in the same patient from point A to point B over a period of time. So it really needs to be, or the person should be really experienced in doing these type of studies, or rather experience matters a lot when we are doing these things. So what is the issues when we are having or when we are diagnosing the furcation involvement? Yes, clinical measurements which are to be measured, the vertical loss of bone, the horizontal loss of bone, assessing the loss of attachment is a very important thing which we have to counter, which we have to really take care of. And also interpreting the residual bone support which is available on the radiograph, maybe by IOPA or maybe by CBCT, is another issue which we need to look into. At the same time, the root tooth anatomy which needs to be assessed by the operator, and the amount of residual bone dimension which is available, that also has assessment which has to be done, is a matter of or is an issue which has to be looked into. So if you see the diagnostic challenge, it is basically how we try to integrate the clinical picture which we have and the imaging picture or the radiographic picture which we have. So we have to combine both of this in our mind and make a map of the furcation region which we are having. And all this is actually more complex, made complex because of the furcation which is present over there, the type of the intrabony defect which will be present there, and the craters which might be present around the molar tooth, which is going to make it more challenging for a clinician to make a map or make a picture of the tooth and the surrounding bone in the mind to make the treatment for the furcation region more complex. So when we are coming to the decision making, as to what type of treatment or what needs to be done when we are having the problem of furcation in the region. This is taken from a textbook, Walter Hall. Please do not see on this side of the, because I have purposely placed a cross on that so that you're not able to visualize it, because it gives two types of lesions over here. One is the Furcation invasion and is the infrabony defect. So I want you all to concentrate only on this side. So when we are determining the Furcation, you have the grade 2 and grade 3 type of Furcation. We need to decide what we are going to do. When we are having grade 2, well, this is given in the textbook, less than equal to 3 millimeter. Just a minute, sir. Just a minute, sir. Hello. Yeah. So when it is less than equal to 3 millimeter horizontal penetration, they suggest doing an apically positioned flap and osseous resection. And when you have greater than 3 millimeter of horizontal penetration, they are asking to see if it is in the interproximal region or it is on the buccal and lingual furcation region which is present. If the interproximal area is the area where the lesion is present, they are advising the root resection and extraction. Whereas if it is present on the buccal or lingual side, the furcation, you can go in for regenerative therapy like your grafting or GTR or something like that. Once that is done, they have been asked to assess or reassess this after a 12-month period. After 12 months of surgery, reassessment of the area is required to be done. And when the reassessment is being done, if the pocket is present and it is less than equal to 4 millimeter, you can put the patient on maintenance therapy every 3 months. If it is greater than 4 millimeter with bleeding on probing and there is some residual defect which is present in the area which we are able to visualize on the radiograph, a second surgical procedure is advised where you can do an apically positioned flap and do some osseous resection in the furcation region to make the area cleansable. And well, if the pocket depth is going to be the same as it was before the surgery, they have considered to do the periodontal regenerative procedure all over again in the article. If you see the treatment algorithm for the molar tooth, which has been taken from the systematic review by Avila and Oritz et al., when they are having the maxillary and mandibular tooth where furcation is involved, if it is a class 1 type of furcation involvement, there is no regenerative therapy which is recommended. We all know that. But when there is class 2 and class 3 type of defects or furcation involvement in the molar, in the maxillary or mandibular molar, they have got some general recommendations to do the therapy as well as to show or rather have some evidence as to whether this can be done or not. So if you are having a maxillary class 2 or a mandibular class 2 type of furcation involvement, they have advised regenerative therapy which can be done in those regions. And they have also shown, you can see the plus marks over here, that the evidence shows regenerative therapy yields superior outcome as compared with conventional surgery. So only doing a flap surgery when compared with doing some grafting technique, regenerative technique, the regenerative technique showed better result than just doing an open flap debridement. And also the histologic evidence showed that there was presence of new attachment when the regenerative surgeries or regenerative approach was being applied. In the class 3 type of defects, we saw in class 2 they have written as may be indicated, whereas in class 3 they have written as could be indicated. There is a difference in the wordings you can see, and they have already put that in yellow over there. So when they have mentioned it could be indicated, we know that there was not much of a difference when the conventional flap surgery was done or a regenerative therapy was done. There was not much of a difference. That is why the minus sign you can see in those areas. And the histological evidence you can see in the maxillary class 3 type, there was no much histological evidence presence. present, but definitely in the mandibular class 3 type of defect, when the histological sectioning was done, there was some amount of new attachment which was visible. Well, my thinking goes probably because class 3 mandibular being a lower tooth, the graft which is being placed remains in the area for a longer period of time when compared to the maxillary teeth. That is why probably some amount of new attachment might have taken place, which shows histologically in the section. So that is my understanding. I mean, others may differ if
Okay, Saraswati Dental College.
so,
Got
if you see the prognosis of a Furcation tooth, it depends on actually several factors. It depends choice of the appropriate treatment modality for a given clinical situation depends wide variety of factors ranging from the age of the patient, the condition of the patient, all patient related things, what type of periodontal disease he's having, whether it is the chronic periodontitis or aggressive periodontitis, and what is the importance of the molar tooth in the entire dentition, what is the degree of furcation involvement which is present, in the morphology of the tooth. I have written the concavity of the root, the size of the furcation, root divergence, crown root ratio. All these things play a very important aspect. Another two important aspects which play an important role in the prognosis is the operator's skill and experience. An operator who is new in treating furcation region as compared to someone who has got maybe 10 years, 12 years, 15 years experience, definitely there is going to be a difference in the skill in doing the regenerative or any other approach when the furcation is being treated. But the entire thing doesn't end here. The most important thing which depends on the patient, the ease with which the furcation area can be maintained by the patient. If the patient is not motivated to maintain the oral hygiene in the area, in the set area, the entire treatment which we are going to do is going to fail. So a lot of factors are there which actually make or decide on the prognosis of a furcation involved molar tooth. So the furcation therapy, resective approach and regenerative options are available, which basically depends on the degree of the furcation involvement. So basic things I have told, same thing I'm telling you once again over here. Patient compliance is very important in this thing. I mentioned you in the last slide also. If the patient compliance is not there, we are not going to reach anywhere with our therapy. I will just show you some pictures. Of course, this picture is from a textbook. I do not claim any thing for this picture. It is taken from the textbook. But whenever there is a furcation involvement, furcation plasty, when we are doing just the initiation of the furcation methods, there just reflect the flap and do some odontoplasty in that area so that the furcation becomes self-cleansing and can suture the flap back. So this is one of the treatment modalities which has been performed. Management of 1 minute, sir. Grade 2 furcation over here we can see with the use of membrane. You can see that the furcation is involved over here. You can see the probe going inside, the flap being reflected, and you can see the the material being applied, and over a period of time, after about 1 year, you can see, of course, I agree the probes which have been used are different probes, but you can see that the attachment has taken place. The probe is not entering into the region over here. Another case, you can see the entire furcation after the reflection of the flap. You can see, in fact, the radiograph, if you can see, the entire distal root is involved in this area. The endo treatment was initiated for the patient. And then on reflection of the flap, you can see a lot of specks of calculus still present on the root surface over here, which was not being able to be removed. And this is one of the causative factor for the loss of bone in this region. And a debridement has been done. and the graft placement has been done over here and sutures have been placed. This is about 1 year post-operative. You can see the bone fill. I'm not telling regeneration or new attachment here. I am telling this is bone fill, because regeneration I would not be able to tell until and unless we have a histological section over there. So bone fill, you can see that there is good amount of bone fill over a period of 1 year, which we are able to visualize. Another case where we are placing the GTR membrane in grade 2 furcation, you can see reflection of the flap and debridement of the area and the membrane being placed over here. This is the pre-operative and post-operative radiograph which are there for you to visualize. Case where emdogain is being used in the furcation region for regenerative therapy. You can see the probe, neighbor's probe going inside. This is to measure the vertical defect, how much of bone is being lost. The flap is being reflected. You can see the granulation tissue, debridement which is being done, emdogain being applied, and then the membrane which is placed over here. You can see the pre-operative before the root canal was done, after the root canal has been done, and after the periodontal therapy has been done. This is about 1 year post-operatively. Not much of bone fill which I would appreciate in this type of defect over here, but emdogain is being used nowadays as well. Another case, you can see the radiograph. Of course, both the radiographs are a little bit in different angulation, but a case of furcation involvement in the mandibular molar where PRF is being used as a regenerative material to in the furcation region, and you can see the radiograph which has been taken after 6 months time over here. Membrane placement, furcation region, again grade 2. This is minimally invasive technique which we have done here. You can see only the molar area we have given the incision. Usually when we are doing, we extend one tooth easily, one tooth distally, but here only the molar tooth we have reflected vertical releasing incisions have been given and reflected, and the membrane has been placed over here. You can see this is the pre-operative radiograph and 1 year post-operative radiograph which you can see over here. Root resections, another important thing. Root resection is basically done when the interradicular bone and the root surface itself is involved with the periodontal disease, and we want to eliminate those defects and the deficiencies. So we do the root resections. You can see here the first molar, maxillary first molar, involvement of the mesiobuccal root is there. So the root canal treatment has been performed for the patient. And then you can see the reflection of the flap and the furcation involvement you can see over here. And after the debridement, the mesiobuccal root has been resected over here, and some debridement has been done, and PRF has been placed here in this region. So this is the radiograph after the root resection was done. Another case of root resection, the distobuccal root is involved over here. You can see after the flap reflection, the distobuccal root has been resected over here, and this is the radiograph. Another case, distobuccal root resection. And this is a radiographic picture for you to show 9-month follow-up done by my postgraduate student. You can see the root which is involved, the mesiobuccal root which is the mesial root which is involved over here, and you can see the cut which has been given, and radiograph has been taken before the reflection of the, or rather before the removal of the root from that. This is immediate post-op, and this is 9-month post-op. You can see here in the first picture the amount of residual bone remaining, and because of the lesion which is present. Once the lesion has been removed, debridement has been done, you can see the amount of bone which has again regenerated in this region. So this shows that elimination of the inflammation and necrotic tissue definitely gives better chances of healing. This is not loaded, and I do not know whether to load this because there is still so much of gap present over here. But comparing the amount of bone which has been lost over here to the amount of bone which we have gained over here, this is a phenomenal result over here. Another case where root resection is being done over here, you can see the distal root which is involved. The root canal treatment has been performed, and you can see the distal root has been amputated with the crown. Rather, hemisection has been done here. You can see it has been removed, and the crown has been placed. You can see the clinical picture over here. The area where there is space here, the pontic has come here like a premolar over here. So there is a bridge which has been placed in the region. Bicuspidization, another technique where you will split the tooth into two and make the molar tooth into two cuspids. You can see the involvement of the furcation in the molar tooth over here. The flap has been deflected. Of course, the root canal treatment has been performed. The tooth has been split into two. You can see after the healing is complete, the two tooth, the preparation of the tooth surface has been done to load them with individual crowns. This is the lab picture where the crowns have been designed, and here they have been placed in the oral cavity of the patient. Two molar tooth which has been converted into two premolars by cuspidization. Another case, tunneling, which is very important for the patient to maintain the furcation in the oral cavity. Grade 3 type of furcation where your probe goes in through and through, but it is covered by the gingiva. It is not, the furcation is not visible in the oral cavity. So here we reflect the flap, done the debridement, and we have apically displaced the flap, apically displaced so that the furcation is visible in the oral cavity for the patient to maintain it, or rather use some interdental aid so that he can maintain. You can see the probe going through and through in the oral cavity over here. This is basically how the interdental aid is going to be used in the furcation. Interdental brush can be pushed in through the furcation to maintain the furcation region. All the debris, plaque which gets accumulated, you have to instruct the patient to use this type of interdental aid so that the furcation region can be cleansed at least once before the patient goes to bed at night. This is a clinical case again to show you. You can see the furcation region which was there in 2005, and it is this second radiograph is taken in 2019. So it's roughly about how many 10-14 years follow-up of this patient. Here you can see the amount of bone remaining in this patient, and surprisingly you will see the amount of care the patient is taking to maintain the oral hygiene. You can compare the bone in both the radiographs and see how the patient is motivated to maintain his oral hygiene. You can see the furcation region which is kept open in the oral cavity over here, and you can use the interdental brush. Little bit of chlorhexidine stains you can see here, and a little bit of calculus which is present here, but otherwise the patient's gingiva, if you see, it's nice pink in color, very firm and attached. So this is the level of motivation the patient should have when we are maintaining oral hygiene or maintaining the dentition. There is a nice systematic review which has appeared in Journal of Clinical Periodontology in 2009, which basically evaluates different modalities of treatment in the furcation region. We have various treatments which we are doing in the furcation region, which needs to be evaluated as to what is the result which we get with these type of treatments which have been done. If you see this uh, systematic review, they have compared or rather given results or rather survival rate of the molar tooth based on the treatment which is being carried out for them. And if you can see the number of years these studies have been or these patients have been followed up, it ranges very much. If you see the non-surgical therapy, that is only the scaling and root planing, which has been done in cases of class 1 percussion, two studies were evaluated, and the patients were evaluated over a period of 5 to 12 years, long period of time. And survival rate of the molar tooth in these type of studies is seen to range from 90 to 100% survival rate of the percated tooth. 3 studies of tunneling procedures followed up for up to 12 years. It shows a survival rate of the molar tooth from ranging from 43% to 90%. That is also a good rate of response rate over here. Surgical therapy, where only open flap debridement is being done. 10 studies have been evaluated, ranging from 8 years to 22 years. 22 years is a very long duration of time. And the survival rate of the molars has been seen to range from 43 to 96% in this type of treatment modality. Hemisection and root resection, 10 studies followed up to 10 years. You can see ranging from 58% to 100% survival rate when hemisection or root resection is being done. And regenerative therapy, only 4 studies were followed up or rather recorded. Again, went on to for about 10 years. Here again, depending on the type of regenerative therapy which is being done, the survival rate of the molar is seen to range from 62% to 100%. So all these studies, if you see, minimum at least they have been followed up for 10 years, at least minimum 10 years they have been followed up. So the result which is being shown, the survival rate which is being shown, which is ranging right from 42 or 43% to 100% survival rate. So basically all these studies, the systematic review shows that if we are doing a treatment, we as a periodontist, retention of vast majority of the furcated tooth is definitely possible. We definitely have to strive towards maintaining or retaining these furcation involved tooth in the oral cavity, which has its own function. And if you see the resective surgery treatment alone in the Furcation region, again, it's a systematic review which just appeared in December 2019. And all these cases are in patients or rather tooth which were diagnosed with periodontitis stage 3 or stage 4. And definitely after we will see, look at the class 2 furcation and class 3 furcation, where survival has been looked into, survival of the molar tooth. And if you see the resective surgeries which were done, that is your root resection or hemisection or whatever resective type of treatment is being done in these regions. You can see in class 2 furcation, 3 studies have been involved in the systematic review, and it shows up to 86% survival. And in class 3, 4 studies have been included. It shows 79% survival rate. Similarly, tunneling, only 1 study has been included in the systematic review, shows about 67% survival rate. And in class 3, 2 studies shows up to 67%. Open flap debridement, again, 3 studies have been followed up for class 2 as well as class 3. Which shows survival rate up to 93% and 75%. And of course, the main things are scaling and root planing, 3 studies in class 2 and class 3 shows up to 82% and 73% when we are doing only scaling and root planing. And RSRP, that is repeated scaling and root planing over a period of time. Both class 2 and class 3 included only 1 study which showed about 85% survival rate. and 45% survival rate in class 3 type of furcation defects. So survival or making survival possible for the furcation involvement tooth, whether you do some resective or regenerative type of therapy, is definitely possible. We need to apply our mind and do it, because nowadays what we see is, as I mentioned in the first part of my presentation, we all need to just want to extract it and put an implant over there. But a natural tooth definitely has its own importance in the oral cavity. So to conclude, I would say, I think I am on time. Yes. So to conclude, I would say that prevention has a lot of emphasis. Has to be placed upon the prevention of the periodontal disease, and also early intervention. It is possible from making the tooth, or rather making the involvement of the furcation more deeper, extending it from class 1 to 2 or 2 to 3. We should prevent that. So that is very important, and early intervention is important. Diagnosing and treatment is definitely possible. We have various modalities which can be done depending on the stage or type of lesion which is present in the furcation. We are able to diagnose and treat with all our latest diagnostic aids that are available for us, ranging from the clinical as well as the radiographic availability. Treatment strategy as to what type of treatment in which type of lesion is required is important. And patient monitoring during secondary prevention after the treatment has been performed, whatever type of treatment, maybe just SRP, OFD, tunnelings, resection, regenerative. You should have the maintenance protocol for the patient, to recall the patient and place him on the maintenance protocol, so that further secondary periodontal disease can be prevented. And as I told earlier, implants to be placed as late as possible. First and foremost, we have to understand that we are periodontists. Our main goal is to retain and restore whatever teeth is there in the oral cavity, and implant is not a treatment for periodontitis, right? So implant is not a treatment for periodontitis, so we have to understand. And the last line which I have mentioned in red, furcation involvement is definitely manageable. We can do it, and we shall do it. Thank you very much, sir. Thank you for your patient hearing. I think I have exactly finished in 1 hour as told by you. I am open for questions.
So very well presented, sir. And I'll be very honest that Bala sir has explained everything in a very, very, very simple manner with good references. And I think all the students, all the postgraduates must have learned the way how things have to be presented. And sir is one of the icons in periodontology that you should be followed. And sir, it was very nice, very explanatory, very basic. And the best thing is the job of a periodontist is to preserve the natural periodontium, not to run after the latest technologies of implant. Implant should be one of the last resorts, which when we really can't save the tooth. And well said, sir. Over to Dr. Benz. Dr. Benz, sir, are you there, sir? Sir, please, sir.
Thank you, Dr. Bala, for a wonderful lecture.
Thank
And
you,
I appreciate other faculty members also. Just a minute.
Good morning, Pradeep, sir.
We have Dr. Pradeep Tandon with us also. We had Dr. Sanjay Gupta, I guess not here right now. Dr. Amitabh was there. Dr. Varsha Rathore from Mumbai was there. Dr. Gurpreet from Chandigarh was there. Dr. Mona Sharma was there. And other faculty members from various dental colleges were also there. And thank you, Dr. Bala, for the wonderful lecture. And this is, I'm just sharing the certificate.
Pradeep, sir. Good morning, sir. Pradeep, sir. Sir, unmute yourself, sir.
Yeah, good morning.
Good morning, sir.
I'm very happy to see that you are taking a topic which is of not only in the implantology, but also to save the tooth. The line you said that the periodontist should be interested in saving the tooth is a basic criteria. Why not
Sir.
go for this?
Sir.
I appreciate that.
Thank you, sir. Thank you, sir.
Dr. Bala, here is a certificate of appreciation for you, sir.
Thank you, sir. Thank you very much, sir.
And we will send this certificate. We will send this certificate via email to you.
Right,
And
sir. Right, sir.
I'm thankful to all the participants who actually took time and participated in this program. Thank you very much. Thanks to all. Thank you.
Thank you. Actually, I was expecting some questions from postgraduates, but nobody is
But
asking.
nobody asking question. Actually, they must be busy.
Because this is a very sought after topic. Even in UG, we say Furcation involvement, and PG, whenever we see, they all want to do such cases. But I was expecting some questions actually.
We too were expecting, but students are a bit.
My basic idea was to put into picture something which we are coming across in day-to-day practice, and how we should approach that problem. That was my idea.
Dr. Bala, this is one message from Dr. Varsha for excellent presentation, Dr. Balaji. It is for you.
Thank you. Thank you. Thank you. Thank you, Varsha ma'am. Thank you.
Thank you, Dr. Sir. Thank you very much. Thank you.
Thank you, sir.